Hello, doctors. Welcome back. I know you guys all have given the exam, and you must be very, happy. Actually, the paper compared to the previous year is much better, and definitely all the questions from microbiology were straight, easy questions only. Maybe a little bit one or two confusing. So, what I have noticed until now with all the whatever the questions shared by the students, so I can see that there are totally from microbiology alone 17 questions. In that, 2-3 questions were combined with Parma, Derma, I could say. Otherwise, most of the questions, as expected, I always used to say, keep at constant 15 to 25, somewhere there 20 plus one or two minus, like that only. Okay. So you see, bacteriology had maximum as usual, we expected. And of course, virology 2, myco 2, parasitology mentioned 1. Probably there are one few questions students might have forgotten to tell also. That's okay. So now let us start the questions. Okay. So look at this bacteriology question. Try. It's a very easy question only. Directly they've asked. So this is a sewage 20-year-old sewage worker. So whenever the sewage worker comes, one disease that comes to mind is leptospirosis. Okay, leptospirosis. That itself is enough. But then you can see it. They've given 1 week of fever was there and generalized weakness, conjunctival redness. Some said it was there, some are not sure. But okay, whatever it is, doesn't matter. The most important lab diagnosis, you see an elevated bilirubin and a decreased urine output. Okay, this itself is giving you a clue. Some hepatorenal syndrome sort of thing is there, right? So that is basically when you talk about this type of in your LFT, liver, or renal function test KFT, right? Hepatorenal, right? Hepatorenal problem is there. Hepatorenal problem is there. Basically, it is ectohemorrhagic fever. Ectohemorrhagic fever. Ectohemorrhagic fever. When you say ectohemorrhagic fever, this is another name for Weil's disease. Okay. Ectro because of liver problem. Hemorrhage because of hemorrhage only you are having conjunctival redness and also associated with the renal failure also. So your combination will go towards Weil's disease. Enteric fever rule out. Dengue, no any link. Brucellosis, there is no any food, milk history or anything. Okay. It's not a zoonotic, any history is not given there. So it's directly Weil's disease. Okay. Leptospirosis, sewage worker. Usually we remember it as RRR. Rain, rat, rice field. That's the clue. But here they're given sewage worker. That's it. So it's a leptospiro, your Weil's disease, okay, which is a leptospirosis. Okay, fine. Next. Easy question that is. So next question you see here, a patient, a pediatric patient, Group A, Streptococcus is the most common cause of bacterial pharyngitis. Of course, that is your Streptococcus pyogenes. You know that. Which bacterial structure facilitates the attachment to the epithelial lining? Attachment. So we know that whenever attachment, you think about pili. Pili or fimbria is the attachment, but also there's one more structure. Now let us see here. There's a group A Streptococcus. That is basically Streptococcus pyogenes. Streptococcus pyogenes. And what is it? It is a gram-positive bacteria. Okay, it's a gram-positive bacteria. For positive people, we remembered, if you remember the shortcut, we told, remember PPT. Positive people make PPT. Other P's have not described. That is a thick peptidoglycan layer. You have pentaglycine bridge, purple color. T is the one we're talking here. Positive, that is teichoic acid. Teichoic acid means itself, we told, like Fimbri, this is for attachment. We repeated it many times, attachment. Okay. Teichoic acid, attachment. So directly, teichoic acid is given. Capsule is for protection, flagella for motility, lipopolysaccharide is for producing your endotoxin. So no link with this. So your answer is this one. Okay, if these are the options given. Next question. Here you can see here the given in a village, many people after consuming raw milk from the same source. Okay, raw milk. Okay, they have drank from same source. They developed dysentery. They had a dysentery. Okay, on stool examination, curved negative. I mean gram negative curved bacilli. Okay, that is basically rods. Okay, the ideally here it is like a rod. It is a bacilli or rod. I don't know what was given. Rods. Okay, with it is a, what important here is, it is the poly-PMN cell infiltration was seen in the stool. Okay, so which of the following is the likely causative agent? So first of all, milk itself gives you clue. When you take about raw milk, usually and with diarrhea, the combination mostly goes towards the Campylobacter only. Campylobacter, yes, but there can be other sources also. Staphylococcus aureus also can cause. But you look here, it is clearly given gram-negative curved bacilli. In this itself, I'm going to rule two things. Your Staphylococcus aureus is gram-positive out, gram-positive out. Okay. Vibrio can be, but Vibrio parahemolyticus, again, based on this picture, milk, it's not coming. It's usually seafoods. It's mostly the seafoods. Okay, so that's also rolled out. Now, finally, I'm going to Campylobacter jejuni. Even that, if I'm not remembering that, also curved bacillus. If you remember Campylobacter jejuni, that is We remember what? Gully Boy, Guillain-Barré syndrome, Gully Boy. I told, we remember it as Ranveer Singh and the Alia Bhatt story. So they do what they do. They love to make a camp. We told they love to make a camp. And when they make a camp, around the camp, what happened? They're having poultry. Those two are not doing thermophilic because there is high temperature inside. Oxygen is low, microaerophilic. Those different stories we're not talking about here. And Guillain-Barré, Gully Boy, because Guillain-Barré syndrome is complication. We're not interested. But if you remember always, I used to write around this camp, I used to draw a seagull bird. That seagull bird is basically this curved bacilli. Okay, this curved bacilli is exactly looks like this. It looks like this. So that's what they've asked. So Campylobacter jejuni is your answer. Very simple, no? It's easy. Okay, fine. Okay. I think you've done. Yeah. So don't worry, it happens. Okay, you go through my notes, you will find it all. Everything is there. It's very easy. Okay. So next question you see, another very easy question. A mother reported 5-year-old child experienced with the nocturnal parent leaching. I'm going to stop there. Nocturnal parent leaching is more than enough. There is only one parasite that causes, that is your Enterobius vermicularis. Repeatedly asked question, many exams. Okay, Enterobius vermicularis. It's also called pinworm, threadworm, seatworm. Pin, thread, seatworm. Okay, but then there was some story was given. Her mother observes a thin worm in the stool. Yes, that's what. That's a pin or thread, white color worm on the stool. You don't see the worm parent region. You can see, you don't see the egg in the stool, but you can see the worm in the stool. Okay, so you definitely, then they have done this adhesive tape skin test. They have done around the skin, around the perianal area. They stick and take it and make a microscopy, and we see it. And when you see that microscopy, what happened? You remember always when there is babies having nocturnal itching, the baby will always say dada mama, dada mama, dada, because the D-shaped egg. It's a plano-convex D-shaped. That is plano-convex. For remembering, we remember D-shaped. Basically, you call it as a plano-convex. You see this egg, plano-convex, D. Okay. Mama, but that's because of drug of choice is mebendazole. Everything you go albendazole, here it is mebendazole. That's what's clue. That's fine. So now everything is given here. So directly you mark as Enterobius vermicularis. Finished. Your answer. Okay. Very simple. No? That's simple. I'm sure you guys made this question correctly. Okay. Next question. Look at this question. A patient, again here, a patient present with a chronic weight loss and low grade fever. First clue itself is enough. It looks like a TB. It looks like a TB for me. I'm going to write TB there. Okay. In the fungal culture, they have done a sputum sample. They have taken a sputum and then they revealed the organism showing a narrow-based budding yeast cells. Okay, budding cells. So now this is not a TB. It is a fungi. So it is going towards the clue. It's going towards it's not a TB, but it is a fungi. So we always said the one that mimics the TB is your histoplasma. That itself is first clue. Histoplasmosis. Histoplasmosis, if you remember. Hi, darling. Let's go to cave, Ohio cave, and do some romance. Inside the cave, there was this bat. And because of bat, what happened? They end up the couples, the boyfriend and girlfriend get what? They get the histoplasmosis. That was the way we remembered it. Okay. So now what happens is that, so histoplasmosis is narrow-based budding. It will be like this, right? It will be like this. On contrary, blasto is broad shape. This is narrow shaped and intracellular. So I don't know. Now the picture was given. I think this first picture was given. Second picture was not given, right? But here is mentioned. So these touches you're seeing inside. Okay, if you see inside, see these are the tiny narrow-shaped budding yeast cells. Narrow-shaped budding yeast cells. Okay, but this is the yeast form. But you remember your histoplasmos is a dimorphic function. So you have mold form also. So when you go to the mold form, this is whatever you're seeing here. You see outside like this, tuberculate, right? Tuberculate. So tuberculate. TB and tuberculate. These two words are coming. You see, the disease, first of all, it mimics like a TB. The disease mimics like a TB. And here the form is called tuberculate form TB. So this go towards your histoplasmosis. Directly you can mark histoplasmosis. Okay, very easy, right? So it's tuberculate form, macroconidia, tuberculate macroconidia, and the narrow budding yeast cells, and then the symptoms very much like a TB. This is enough to say it's a histoplasmosis. Okay, you got it. Next question. Next question, if you see, a patient was admitted with a history of chronic meningitis. Chronic meningitis, and lab investigation, they showed a gram-positive filamentous branching. Okay, filamentous branching. So, another, that we are going to talk, a lot of gram-positives have come. Whenever we have gram-positive, we told that, what, please, if you're positive, go and eat in the McDonald's. So, you're going to write a McDonald's down. McDonald's, okay, O is not there. So in this, we've repeatedly said that two of them are showing what? Filamentous. So one is one A and other one is N. N for nocardia. Filamentous. When filamentous means like this, right? They look like this, filamentous. When you talk about gram positive filamentous, it's nocardia, and other one is your actinomyces. And I gave you clue, nocardia, Nora Fatih, our Nora Fatih, Nora Fatih, Nora Fatih. Everyone loves her so much. She's an acid girl. She's a fast dancer. Okay. She's a fast dancer. We call, okay, she's a fast dancer. She needs pure oxygen to breathe, Nora. And next one, what? Everybody's putting bait on her. I repeatedly told several times, I told, and this question came after so many years, it has come now. Okay, in revision classes, I've told to all those students. Okay, so bait. So it is a fast oxygen and bait. You got all the clues. So it is definitely, and also see, they've given Zeal-Nielsen stain was positive. Zeal-Nielsen is basically acid fast. That is acid fast bacilli they mean to say. Acid fast or Zeal-Nielsen, the same only. Paraffin bait culture. You got it. You already got the clue. Everything was in our revision. We have repeated many times. Okay. So this is the thing. So your answer is what? Nocardia. Close your eyes and mark neuropathy, nocardia. That's it. Okay, you're done. Next one, the farmer presents with the, next question, if you say the farmer presents with the necrotic ulcerative skin lesion. We don't know, some skin lesion was there. On ulcer staining with the polychrome methylene blue. Polychrome methylene blue. You already have a clue there. What was the clue? If you remember, what was the clue we're talking here? The clue is basically, yes, the clue is methylene blue. If you stain, what happened? An encapsulated bacteria seen. Whenever methylene blue staining for capsule, usually for capsule, you stain gram negative, right? You do, generally for all capsule, you do negative staining, negative stain, right? It's India ink, the other one is nigrosin. But we told, especially for anthrax, so our clue was Andrea. Andrea means Andrea. Andrea's boyfriend is McFaddy, Maddie, right? Maddie, we say. So here we do this reaction called McFadden reaction. McFadden is reaction where in McFadden there's only one thing, what you're using methylene blue. M for M, M for methylene blue. When you're using a methylene blue, you get a purple color, capsule is visible. That is only for anthrax, only for Bacillus anthracis, not for any other thing. So exactly. So this first clue was this necrotic, that is basically a malignant pustule. That is your malignant pustule. Sometimes people call it as what? They also call it as a, if you remember, eschar, like a scrub typhus. Okay, that's it. So next is polychromethylene blue, a capsule is present. That's enough to say Bacillus anthracis. Very simple. And you know, anthrax has an amino acid because why only methylene? Because of amino acid. It doesn't have polysaccharide, it has polypeptide capsule. That's the reason. Methylene blue stains it. Done? Very good question. Okay, nice. So I hope you guys done. Okay, otherwise also don't worry. Until result comes, be positive. You will get good things only. Okay. Yes. Next question you see. A patient, this is derma related. A patient presents with an indurated plaque on the cheek demonstrating central atrophy. Okay. That is basically, I don't know picture was there or not, but basically that with this plaque and central atrophy is basically lupus vulgaris, right? Lupus vulgaris. Lupus vulgaris, we know this is the most common skin lesion in the TB. TB skin lesion, if you talk about TB skin lesion, lupus vulgaris is the most common one. Now, chest radium, calcification of lung is seen. Chest X-ray, you're seeing a calcification. So what else you need? Two clues you got already. Lupus vulgaris, and you have a apical region, you have a TB, that is basically secondary TB. You got the clue. So automatically, now which diagnostic investigation should confirm the diagnosis? So basically, they're asking TB, how do you confirm the diagnosis? In option, if I had got a culture, if it was given culture, definitely that is a gold standard, right? Gold standard, I'm going to choose it, but here not. More, even last year, if you remember, last year in this one of the our in the INI-CET question, it was given the spine, TB spine. I don't know how the question was asked. That people said for more confirmatory and whatever what it all this extra pulmonary. I told there also in INI-CET also, it is always you go with a gene expert or CBNAT, gene expert or CBNAT. So gene expert CBNAT is basically PCR only. So here to confirm you do PCR. Manto is not a confirmatory test. Slit skin, it's for leprosy. We are not going to use it here. Sang smear for all your herpes simplex or any herpes zoster or simplex infection. So easily, even if you rule out like that also, you can easily mark PCR, right? Is it easy? No? Yeah. So another happy question, I would say. Next question. Again, TB has a lot of questions. Always. excuse me, two questions from TB always comes. Okay, this one was repeated question. I told several times, and during classes also, every time. So don't forget this one. I said. So again, you see the question basically. A 36-year-old man has fever, weight loss, chronic cough, pulmonary tuberculosis. He has a pulmonary tuberculosis. Fine, and he's a HIV patient also, HIV positive. CD4 is 42 cells, something that was given. Okay, so he's having HIV plus TB is there. So we already know, we said many times, when a patient is having HIV plus TB, you have to always treat the TB first. Okay, you're going to start the ATT first, and then after 2 weeks, first always ATT, then go 2 weeks. After 2 weeks only, you will start what? You will start the ART. This is the clue, okay? Because suddenly when you're decreasing, if you give first time itself that ART, the lymphocytes start to increase, and then what happened? You will get a hypersensitivity reaction. So minimum 2 weeks gap is needed. So that's one. So here it was given start ATT first, the TB first, and then initiate ART. After 2 weeks. After 2 weeks, something related to 2 weeks was given. 8 weeks is too much, not that much. The gap between the two treatment, you always TB first. Treat the TB first and then go for HIV treatment. The gap should be 2 weeks minimum. Okay, that is the clue. Okay, so if something question was there, then this is the one you have to answer. Okay, next one, again same treatment with only. See, again the following complications should be closely monitored due to overlapping effect of TB and HIV. We told that the reason is this only. The reason why when you give together problem, I told what happened when you suddenly give both at same time, what happened? Your lymphocytes suddenly start to rise. CD4 cells, it start to rise, and when it is increasing, it causes type of hypersensitivity reaction. That reaction is basically called immune reconstitution inflammatory syndrome. If you have this question, another question is correct. Okay, that's all. Very easy. Now, next question. Again, more related to this only, Parma. Here, a college student has been in close contact with a roommate who recently diagnosed with a meningococcal meningitis. Meningococcal meningitis, the carriers are always here, in throat only their carriers are there, which carry this Neisseria meningitis in the throat. So which of the case is the drug of choice of prophylaxis? Usually, the main drug of choice and treatment both is ceftriaxone. I repeatedly told this question. Ceftriaxone is treatment for both Neisseria gonorrhea and meningitis, always ceftriaxone. Of course, drug of choice for your, which disease? Your typhoid fever, and these two ceftriaxone. Here, what happened? Even for prophylaxis, also ceftriaxone, but here it's not given. So the next option after ceftriaxone is rifampicin. Okay, rifampicin. Here, especially they asking for prophylaxis. So if ceftriaxone not there, then it is rifampicin. I told students, no one told me ceftriaxone was an option. So you can just close your eyes and mark rifampicin. Okay, right. Next question, virology. So that we have done, so almost 11 questions from bacteriology. Now we'll go to the virology. Virology patient present with us. So another easy question, repeated question. Definitely a lot of previous year questions where that I could see here. Okay. Now a patient present with a painful vesicular lesion in the mouth on sang smear. So first of all, first clue for you is painful vesicle. So when there's a painful vesicle in the mouth, the only thing comes to your mind is herpes simplex. Yeah, that is a clue. Now again on sang smear, multinucleated giant cell, MNGC cell with an intranuclear inclusions were also seen. So vesicle, classic HSV, classic, this is a classic HSV. So you have a vesicle and then you have a multinucleated giant cell, Even intranuclear inclusion body also characteristic for herpes. The shortcut we remember, hey, BAP was, I'm not going to talk about that. Okay, this is more than enough for you to say it is a herpes simplex virus. Adenovirus will not cause vesicle. Cytomegalo also, there is no vesicle business there. That clinical picture is totally different. They cause what? Throat pain. Both EBV and cytomegalo cause infectious mononucleosis, right? That is basically kissing disease. That is you have in a throat infection basically. So this is not anything. So it's easy question also. Here also you can rule out and easily mark it. Yeah. I think this time examiners had mercy on all our students. Yeah. Good for you, all of you. Okay. Now the most common causes commercial carcinoma base of the tongue. This is a bit confusing question because base of the tongue or side of the tongue, I don't know, very controversies going on. If it was like oral leukoplakia on the side of plakia, on the side of the tongue, if it's a tongue on the side of the tongue, I would definitely choose Epstein-Barr virus only, right, Elmar? Here it's given squamous cell carcinoma at the base of the tongue. So, and especially when squamous comes itself, you have to think about your HPV, human papilloma virus. Okay, of course, it causes all your cervical cancer, penile cancer, anal carcinoma, and also laryngeal papilloma. It causes HPV, so with all the cervical cancer and all other things. Here also in mouth oral cavity, it causes this squamous cell carcinoma. Okay, that was also one of the discussion point. Okay, now next question in parasitology, middle-aged. Yeah, middle-aged, another easy. I think I'm not going to say easy because for some students, maybe it was they didn't revise enough, so might have made mistakes. So it's okay. We will see. Okay, you will, and we never know exam how it. After result only you'll come to know, right? So let's just now concentrate on what you have done. Okay, middle-aged male presents with the some progressive lower limb swelling. Lower limb swelling is there. So some swelling, and if I see this picture, my mind will go to elephantiasis only. So in the picture, if this picture is given, this is a microfilaria. You can see this is a microfilaria you're seeing here, right? So here, what happened is, so what is the most probable underlying cause? So this is a microfilaria I'm seeing, microfilaria, to say very clearly, see in the tail and no nucleus, in tail and no nucleus, no nucleus also. So I remember, if you have a lot of clues, remember elephant is empty, right? Elephant empty. Or also I used to draw, always I draw for the student this elephant, and I say big elephant, it's a small tail, so there is nothing, there is no nuclei in the tail end of the elephant, elephantiasis. And the main reason for elephantiasis, the leg swelling, is because of lymph obstruction. So that is what they win, which is the mechanism, lymphatic obstruction. Hypoalbuminemia, hyperlipidemia, no link at all. That is totally medicine topic. So when microbiological, it is when this type of things comes, you're going to say it is it is a lymphatic obstruction, elephantiasis. That's all. Okay, fine. So you got it. Now, next question. A patient a patient has fever. Yes, we won't talk this one again. A patient has fever, cough, hemoptysis. Excuse me. Yeah. So here, a patient is having fever, cough, hemoptysis. Again, something related with the lung only. Lung problem is there. And then bronchoalveolar lavage. On the bronchoalveolar lavage, it shows a septate hyphae with acute angle dichotomous. Repeatedly, we were discussing aspergillus and mucormycosis difference, and we always divide, and we talk this many times. So exactly same thing they have given here. You can see a septate hyphae with the acute angle dichotomous branching. Okay, so it's basically it's like this. They have like this. Acute means less than 90 degree, so there's a septate and there is this. So that is basically acute. So we already know that the clue is already here. Aspergillus. Aspergillus means itself, there is A for acute angle, A for acute angle, S for septate hyphae. So close your eyes and mark aspergillosis, right? Yes. Okay. Fine. So mucormycosis is not. Mucormycosis, there is no septate. There should be no septate and wide angle or right angle. It should be right or wide angle. Okay, right or wide angle. So it's out of question. And again, bronchoalveolar, so lung related. So a lot of clues they have given in the question. So you can't make any mistakes, right? No problem. If mistake also, no worries, no worries. Until results come, you don't think about anything. Okay, all will go good and positive. Okay, fine. Next one. Now, a patient, again, this question was repeated many times. I'm so glad that the questions I thought for so many years they didn't ask, those questions have come. Okay. Now, see here, this question, a patient is having a swelling and sinus discharge with a black color granules. Okay. First of all, look at this. When this swelling and sinus discharge comes, it's always mycetoma. And mycetoma can be repeatedly, we saw it can be actinomycetoma, other one is your eumycetoma. And repeatedly we will discuss that what A, after A comes the B. So it is bacteria. It is usually bacteria caused. After E comes the F, so eumycetoma is fungi. For bacteria, even you do a gram stain, and you'll see a filamentous gram-positive bacteria, that is gram-positive bacteria, especially Actinomyces or nocardia. Fungi, you'll do a KOH mount. Usually, I told you when mycetoma granules, if you take, you do either gram stain or you do KOH. This was repeated many times. I told in classes also several times. This is how you're going to do. And do a KOH and you find a hyphae, then that's it. That is your fungi. Simple. So, what is question here? First of all, it is a black color, yes. And moreover, fungi is always black. if you forgot also, you remember in a COVID time, we had mucormycosis, everything, whenever fungi, even the normal people who don't have any knowledge of medicine, so they will say anything black, they say, oh, it's a fungi, it's a fungi. So it's easy to remember, like black color is fungi. Whereas your bacteria usually have yellow color granules. Okay, yellow granules. The granules are yellow there. So this is out. That means you can't think about the bacteria, it's out. So it is a Mycetoma only. So now see the clue, which is most likely finding of KOH. So in Mycetoma, do we see arthrospore? Not at all. Where do we see arthrospore? Arthrospore means I told cock. The cock name is Arthur. Arthur, rectangular cock, that is Coccidiomycosis. So I told, remember, Arthur's cock going on the valley, rheumatic field. I'm not going to talk about that. Okay, out. Slender Demetrius, no. Demetrius fungi usually very rarely they cause disease also, and there is no link. Okay. I forgot about it. Yeast, not at all. Yeast is just Cryptococcus or Candida. Why Crypto and Candida will come in the Mycetoma? So definitely a septate hyphae. That's what I'm saying. This is what we discussed in our many times in revision classes. Everything we told this one. That only has come. Awesome, no? Very good. Right. Next, immunology. In immunology, the patient has a recurrent nasal infection. This is another examiner's favorite. I don't know how many times more. I think 6, 7 times, even more than that in all FMGE or Neetpg, INI-CET have asked. So recurrent nasal infection means itself, the only thing the reason for this is, I know some students said recurrent, some students said related some gonococcus, it was given, related to gonococcus, some disseminated gonococcus infection. So usually, when gonococcus disseminated or meningitis disseminated infections, different type of arthritis. These gonococcus infection can have patient usually have what? Arthritis, water can perineum. So those of the disease, Fitzhugh-Curtis syndrome, those things. Okay, so that is also same thing, because whenever you have this C5 to C9 complement deficiency. Okay, or meningococcus, here it's an Neisseria recurrent. I don't know if it is meningococcus also. In meningococcus, you can get so many diseases like Waterhouse-Friderichsen syndrome, purpura fulminans, when it goes sepsis. So again, this is what happened. This is also when you have C5 to C9 deficiency, it can happen. So either way, both the way in the Neisseria, when the reason for severe Neisseria infection is decrease in the complement. That is C5 to C9 MAC complex. We call it as MAC complex. So that is your answer. Okay, that's all. So 17 questions I've got until now. I don't know, some questions will come later or whatever. But for the 17 question, I think it was a standard question. Yes, mostly easy, but some students, if you find they didn't have time to revise, that's what happened. No worries at all. You always have good chance to get. If not, also, please keep at it and do well next time. So no need to worry at all. Okay, don't worry. Just relax and enjoy. You will do good. This time or next time doesn't matter. I'm not taking negatively. I know that you guys will do it. Okay. So again, more microwave will follow in the upcoming classes. So get good rest and once again, congratulations. Okay. Take care.